We thought we would do a little tendon primer because they're going to come up in a lot of the topics that we discuss. A lot of the biomechanical issues have some sort of tendon issue attached to them, going down the body right from a kind of glute med with its tendon attachment to the greater trochanter, hamstrings into the ischial tuberosity, patella tendons, Achilles tendons, even to a certain degree the plantar fascia. We tend to treat them all in a very similar sort of way. So let's keep in mind that most tendon injuries will happen because of overloading. And when we think overloading, there's kind of two aspects to think about here. The person has done too much for their capacity, right? Their capacity to maintain integrity and function of the tendon. The other aspect of overloading is that the capacity is low. So we're seeing the individual deconditioned for what they need to do, or have they deconditioned over time for their activities of daily living. So we're managing both the loading aspect and the conditioning and capacity aspect. Tendons tend to function as springs. So quite often the loading, if it is a loading issue, will be because the client is either walking more than they have the capacity for, running, jumping, or coming out of where the tendon is stretched, coming out of those positions powerfully. So someone that's coming down from a low squat, standing up very quickly, let's say an athlete that needs to pick up a ball off the ground or anything in that sort of movement pattern. So think of a tendon injury coming out from too much of that rapid springiness, which is what the tendons like to do. So to treat that tendon, we need to be looking at modifying loading, but not stopping the loading. It's very important that a tendon doesn't become deconditioned. So we're modifying what the person is doing during the treatment period, and we're really focusing on increasing the capacity of the tendon itself and the muscles around it. And we'll talk a little bit more about this. But before that, let's talk about a differential diagnosis that can really kind of trap us here. The client may be complaining about pain in the tendon region, and they can point to the tendon itself. And we can have typically one of two things. We can have a true tendon injury, or we can have an injury to the sheath of the tendon, the paratenon. The way that we kind of work out the difference, and it's really important to work out the difference in that when the tendon is damaged, it's because of that springy loading, and that tendon will respond really well to being to its capacity being increased again. So we want to load that tendon for it to get better. We'll talk about the protocols. We definitely don't want that tendon to get deconditioned. The person will feel better if they do nothing, but that's because we've stopped the aggravating action, but that tendon is not healing. So as soon as they go back to their normal activities, they're going to have that problem again. On the other hand, the sheath of the tendon has inflammatory cells, and so it's going to be an inflammatory condition, whereas the tendon itself doesn't have those inflammatory cells. So with one, we're dealing with a tendon issue. With the other one, we're dealing with an inflammatory issue, and we need to treat those two very differently. So it's very important to get the right diagnosis. Clinically, one of the things that's going to start guiding you one way or the other is the history of how the pain actually came about. So if it's springy type of activities, more likely to be the tendon. If it's more rubbing sort of activities, so cyclical movements, for example, someone that has rightly wanted to increase their calf strength, but they've started to do a lot of calf work, for example, or they've increased the loading in the gym, so there's no impact, there's no springing, but there is rubbing, or cycling, for example. Those type of activities are much more likely to affect the paratenon and it becomes an inflammatory condition. If you're unsure, get a scan, right? You have to get the right diagnosis here because the treatments are going to be opposite to each other. An inflammatory condition, you will know how to deal with that, right? That we want to rest, unload, work on the tissues around it, take anti-inflammatories, cortisone's work in this case, because we want to reduce the inflammation and then progressively start to return the client to their normal loads and hopefully make them stronger so they're not in that position again. Whereas the tendon, you definitely don't want to rest. You must load that tendon as soon as possible, and we know that tendons respond to heavy loads. Totally not what you want to be doing with the inflammation, right? So tendon protocols, obviously depending on the body part, but you're thinking isometrics first, so holding a position, right? So for an Achilles tendinopathy, it'll be a calf raise movement. For a patella tendinopathy, it's going to be a leg extension of some sort. For a glute med tendinopathy, it's going to be some sort of a held abduction. For a hamstring tendinopathy, typically we would start with a long leg bridge. So lying on the floor, bridging up, but with the hip in neutral as opposed to bend, because a lot of these tendons also have a compression issue where they're attaching, right? So as we move out, that tendon compresses into the greater trochanter, or the ischial tuberosity, or the kneecap, or the calcaneus, right? So we want to avoid compression. We want to apply an isometric load. It needs to be heavy, held for ideally 45 seconds, not less than 30, not more than 60. So that gives you an idea of how heavy it needs to be. If the client can't hold it for 30, it's too heavy, so we need to modify. If they can hold it for 60, it's now too light, and we're getting decreased returns on our investment. So heavy, held for ideally 45 seconds, somewhere between 3 to 5 reps, ideally 4, with a 90-second break in between. So that 90-second break allows us to recover so that we can apply that next heavy set. You're doing this every second day, typically for a couple of weeks, 2 to 3 weeks before we progress. Your progression then goes to eccentrics. So you might go up with 2 legs, come back down with 1, for example, depending on the tendon that you're addressing. Again, 2 to 3 weeks, every second day. When we're working with eccentrics, I keep the same time frame. So how many reps? About 45 seconds worth of reps, slow and controlled, 2 to 3 seconds up, 2 to 3 seconds down, so that we're not applying that springing load, which is what hurt the tendon in the first place. After those 2 to 3 weeks, then we start going to concentric, eccentric, same sort of parameters for a couple of weeks, and then we're starting to slowly introduce more of the springing, powerful type of movements. So again, tendons must be loaded, not rested, so make sure that you've got the right diagnosis. Now, if you were to gamble, don't gamble with your clients. If you're unsure, get the scan. But this is how strongly we feel about loading the tendon. If you were to gamble and you don't know whether this is the sheath or the tendon, apply the tendon protocols, right? If it's not the tendon and it's the sheath and you're overloading it, then the pain is probably going to get worse for a bit, right? We always tell the client, if the pain gets worse, stop. So we're not going to drag this on, but we'll know that then it's probably more the sheath, it's inflammatory, and we want to take that approach. But if we make a mistake and we start to rest the tissue, we start to take anti-inflammatories that will do nothing for the tendon, we're really missing out on tendon loading time. That tendon is going to become more deconditioned, the muscles around them are going to become more deconditioned, and eventually the problem will be worse. So remember, you must load tendons.